Thanks very much, Prof Madden. Thanks very much for having me here to talk to you about emergency laparotomy in Victoria today. It's nice to come back over to Perth, and this time I'll be getting a flight home. But this audit was put together by myself, but also with the help of Telstra Health, a fellow called Chris Brown, and of course Professor Waters in Geelong. So it's a collaborative sort of an effort. So we'll get on to. So the reason that we did this, and it's after Peter's talk. This is a purely administrative data audit, so it gives you a perspective that's probably a little bit different. But the reason that we did this, and we've called it VILA, the Victorian Emergency Laparotomy Audit, was that we were looking at the ANZ ASM, and this was back in 2014, but we got the same results in 2015, that 85% of the patients in the ASM were emergencies. The mortality people were predominantly in the elderly. 89% of them had more than one comorbidity, 84% of them had an ASA greater than 3. They had reported a delay in surgeons delivering treatment in nearly 70% of patients, and by far the most common procedures were laparotomy and colorectal procedures. So we thought, well, there's a need to audit our emergency laparotomies. The tool that we decided to use was the Dr. Foster Quality Investigator, and this was a database that was in trial in Victorian hospitals for 3 years, and it collects administrative data from all Victorian hospitals. What we did for our audit is involve all Victorian hospitals using the ACHI procedure codes that we selected for non-elective admissions that were what we defined as a laparotomy. The way we decided on and designed this audit was that we would directly compare our procedures in NELA, like what was being done in Newcastle, but it was on the first NELA report, and NELA has since morphed into something that's encompassing more procedures than it did initially. But this is the first NELA report. So we excluded appendicectomies, cholecystectomies, stomal revisions, specialist procedures, hernia repairs where there wasn't resection of bowel, particularly ventral ones, and we excluded laparoscopic procedures. And we looked at emergency laparotomies between July 2007 and 2016. So our overall inpatient mortality was 8.8%. We found that there was no difference between genders, no difference on the days of the week, but the important predictable variables were age of the patient, the procedure that was carried out, the number of comorbidities the patient had, which hospital they were at, and over time the mortality rate changed. So looking at the first predictable parameter, looking at our mortality with age, and you can see I think we could basically ignore the very, very young, but because there are low numbers of patients. But if you look at the mortality in the over 80 patients, these patients older than 80 years are making up 20% of our emergency laparotomy patients or emergency laparotomy population, and they have a mortality of 18%. So they're a significant group that we need to be putting our eyes on. Looking at mortality by procedure type, as you'd expect, division of adhesions is our least problematic procedure, but exploratory laparotomy is sitting there at 18%, and what that procedural group encompassed was the 30373 and the 30369, so the debride and washout of peritoneal sepsis and the open and shut laparotomy. So if you see the exploratory laparotomy code where there's no other procedure performed. And when you look at those two procedures individually, where you washed out sepsis, the mortality rate was down at 7%, but where we did an open and shut laparotomy, the mortality rate was up at 25%. So there are people that we are knowing that's probably not the best to operate on, and they actually aren't the best to operate on. But it's hard to tell preoperatively until you've had that the best CT scan ever, which is a slot in the middle of the abdomen. So mortality rates varied between procedures, and the exploratory laparotomy was the worst. Oh, and you can see there colonic resection with and without anastomosis. So obviously the difference there, well, I would expect that the difference there is patient selection and good patient selection, in that those who got a stoma had a higher mortality rate. Looking at comorbid conditions, Around 60% of patients had no comorbidities and their mortality rate was down at 4%. As you got above 5 comorbidities, then the mortality rate sat around 19%. So there's a significant difference between those types of patients. Across the years, the audited years, you can see a drop in mortality from 2007 sitting at nearly 11% down to in 2015-16 we're sitting at just over 7%. And that's most likely because of the audit of surgical mortality, but it's the same as what was reported in Professor Wattis's paper on postoperative mortality rates in general. So in general we're getting better at patients not dying, but it is important to see that we did see that with mortality, but the thing is that now that has started to plateau. Looking at when patients die after emergency laparotomy, you can see that 40% of the patients that are going to die in the first 6 days, and you'd think that that was reasonably expected. But where there was an extra spike is at the 28 plus mark, and so 20% of our patients that die are dying after 28 days of being in hospital, and I think that that's a significant point to take home. If you look at the graph of complete discharges and deaths together, those two graphs, or length of stay in general, the two graphs are very, very similar. So what we'd seen with this administrative data set was that mortality rates have improved but then plateaued in the last 4 years. The things that predict people dying, comorbidities and age over 80, that was already predicted by the audit of surgical mortality. But the highest risk procedure that we found in Victoria was the exploratory laparotomy, or the open and shut. There are 2 peaks in mortality, the expected one at 0 to 6 days, but the other one at 28 days plus. As was discussed by Peter earlier, the inclusions and exclusions within emergency laparotomy audit will change things significantly, and the things that we excluded and included may have changed what our results are, but I think that it gives us a good snapshot of where the problems lie in emergency laparotomy in Victoria. The restrictions of our administrative data are well known, but Dr. Foster was good because it gave us the ability to look at relatively up-to-date data. When you compare the sort of data that you can get out of the AIHW, the Australian Institute of Health and Welfare, sometimes that data can be quite a few years old. So this was data that was 3 months old at the time that we collected it. The administrative data gives us a great snapshot but doesn't allow us to look at things like the timeliness of treatment, the use of critical care, and so it's an audit without telling us exactly where we're going wrong. It gives us a snapshot of which patients are having problems but doesn't give us a guide for how to improve, and that's why we need prospective audit. And that's all I have.